Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. NIK NIKAM. I'm a cardiologist who has been practicing at the Texas Medical Center for more than 3 decades. Today we are going to look at preoperative cardiac evaluation and cardiac clearance. So let us begin. The objectives of this presentation include evaluation of a patient's cardiovascular risk, evaluation of a patient's coronary, myocardial, electrical and vascular status, review of cardiovascular medicines, diagnostic test for clinical risk assessments, type and urgency of the proposed surgery, intraoperative considerations, postoperative management, resumption of cardiovascular medications in the immediate postoperative period, including antiplatelet agents and anticoagulants. So there's a lot to cover. Let's continue. Patients come to a cardiologist or an internist for cardiac clearance because they have an abnormal electrocardiogram or they have an irregular heart rhythm. They may have a history of coronary artery disease or valvular heart disease. Or some patients may have multiple risk factors like hypertension, diabetes, peripheral arterial disease, kidney problem. Or a patient may have a heart murmur, so they need a cardiac clearance before a simple outpatient procedure. Patients may just come for control of hypertension if their blood pressure is significantly elevated prior to a planned surgery. Or maybe simply because the patient is 65 or older, so they need a cardiac clearance. Sometimes they have questions regarding cardiovascular medications such as blood thinners. If the patient is on aspirin, Plavix or Coumadin, when do you stop these medications? When do you resume these medications? And finally, if the patient is going for a major neurosurgery or thoracic surgery or abdominal surgery, they need cardiac clearance. Doing cardiac clearance is one of the most important roles of a cardiologist. We see many patients in the office and in the hospital for cardiac clearance before a planned general surgery or an outpatient surgical procedure. Every patient, it doesn't matter what their underlying cardiovascular problem is or what their age is, needs a thorough evaluation in terms of: does this patient have coronary artery disease? Did this patient have coronary artery bypass surgery? If so, how long ago was the coronary artery bypass surgery? When was the last time this patient had a functional evaluation of his coronary system? Does this patient have stents? How long it has been since the patient had stent? Did this patient have myocardial infarction? Was it 4 weeks ago, 3 months ago, 6 months ago? These are all very important factors. Does this patient have symptoms of ischemia? Does this patient have reversible myocardial ischemia? Because all of these things can pose problems in the perioperative period. Now let's focus our attention to the heart muscle. We talked about the coronary arteries. Now let's talk about the heart muscle. Does this patient have previous history of myocardial infarction and cardiac enlargement? Does this patient have heart failure? Does the patient have low ejection fraction? Is the patient having dyspnea and pulmonary congestion at rest? Let's turn our attention to the heart valves now. Valves. Does this patient have critical aortic or mitral stenosis? Does this patient have pulmonary hypertension? Does this patient have severe mitral or tricuspid regurgitation? Now let's focus on the electrical system. Electrical system, a variety of conditions can be present. Does this patient have atrial fibrillation with rapid ventricular response which needs attention and control? Does this patient have a pacemaker or a defibrillator? And what do we need to do if they do have a pacemaker or a defibrillator? Next, we focus on the vascular system. Vascular system involves the blood pressure. Is the blood pressure under control? Does the patient have peripheral arterial disease Does this patient have carotid artery disease or carotid bruit? Now let's look into cardiovascular medications. Cardiovascular medicines can be multiple, and majority of them can pose problems in the immediate perioperative period, especially blood thinners and antiplatelet agents. We need to document exactly what medications they are taking and the frequency of these medications so that we can prudently follow these patients in the perioperative phase and resume their cardiovascular medicines as soon as it is permitted. Next thing, we look at the volume status. Is the patient dehydrated? Is the patient volume overloaded? All these things are very important, especially in patients who are already in the hospital, who had multiple medical problems and now needs a cardiac clearance for a major surgical intervention. What is the renal function like? What is the BUN? What is the creatinine? What is the GFR? All these things have a bearing on cardiovascular system because one, related to volume, and number two, related to the metabolism of cardiovascular medications. Does this patient have severe COPD or asthma, which can exacerbate cardiovascular manifestations? Next, we're going to focus on functional assessment of a patient going for an elective non-cardiac surgery. Is this patient able to exercise to a tune of greater than 10 METs, such as working out in a gym, playing tennis, football, basketball, or skiing? Or does this patient have an exercise capacity that is between 4 and 10 METs, such as climbing one flight of stairs, walking on a level ground at 4 miles per hour, and playing golf or running a short distance? Or does this patient have very limited physical capacity? Does this patient get symptomatic while just taking care of daily routines? And these things will enable us to determine how well the patient is able to stand the stress of surgery, volume status, and all the complications that can follow a routine elective non-cardiac surgery. Now let's look at the surgical risk. If we look at the overall surgical population, the overall perioperative mortality is in the range of 0.3%. That's 3 out of 1,000 people going for outpatient procedures, minor surgeries, or even intermediate and high risk surgeries, all put together. But there are some important points that we need to focus on. Cardiac problems account for most of the mortality in the perioperative period, whereas pulmonary problems account for most of the morbidity in the perioperative period. Hence, it is very important not only to focus on heart alone, but to focus on the entire patient, particularly the central nervous system, the lungs, the abdominal cavity, and kidneys. Let's look at the risk of surgery. Here is a partial list of low risk surgery, which means the mortality is less than 1% in these patients. These patients include those who are going for endoscopic procedures, superficial procedures, cataract surgery, breast biopsy or breast surgery, and ambulatory surgery. Now let's move on to the history. Even though we are doing a cardiac clearance for a patient going for a non-cardiac surgery, it is exceedingly important for the internist or the cardiologist to focus not only on the heart but all the other systems which can make cardiovascular function worse. That's why we need to know, does this patient have a history of stroke? Does this patient have TIA, which means they have vascular problem not only in the heart but elsewhere, and hence it is important to watch their blood pressure and maintain their cardiac output in the perioperative phase. Does this patient have chronic obstructive pulmonary disease or asthma, which can make cardiovascular symptoms worse and put undue burden on the cardiovascular system in the perioperative phase? Is there a history of GI bleeding or ulcer or polyps, which can pose problems in terms of bleeding in the perioperative phase which can exacerbate cardiac symptoms. Kidneys are an important organ that we need to pay attention to in terms of, does this patient have chronic kidney disease? Is this patient on dialysis? What is the BUN, creatinine, and GFR? All these things are important because they have a bearing directly or indirectly on the cardiovascular system. Does this patient have arthritis? And maybe this patient is going for hip surgery. So maybe he or she is on non-steroidal anti-inflammatory drugs, which can make bleeding worse because our cardiovascular patients are already on aspirin, Plavix, and sometimes Coumadin. So if you add non-steroidal anti-inflammatory agent on top of triple anticoagulant, antiplatelet combination, we got a problem. Houston, we got a problem. So it is important for cardiologists and internists to pay attention to all these things before surgery, because once they start bleeding in the perioperative phase, it is an emergency. Examination. Just as we focus on every system in the body and see how they can affect cardiovascular function in the perioperative phase, when we examine the patient, we need to focus on all systems, including the cardiovascular system. Pulse. Pulse can tell us a lot about a patient's condition. Is the pulse regular? Does this patient have atrial fibrillation with rapid pulse rate? What is the blood pressure? If the blood pressure is 180 over 100, 110, you know they're going to cancel the surgery, which is a shame because the patient has been dreading this procedure for a whole week, and when he gets into the surgery center, now the blood pressure is 180 over 110 because the cardiologist and the internist didn't pay attention to the hypertension, and the procedure is cancelled, and the patient is really mad. Respirations tell you a whole story about what's happening with the lungs and heart function. Pulse oximetry can also tell us a lot about the patient's underlying pulmonary problem and peripheral circulation. Is there a jugular venous distension, which is indicative of elevated right heart pressures and indirect evidence of a congestive heart failure? Does the patient have carotid bruit? Does this patient have critical carotid stenosis? Because you don't want to send someone for an elective surgery and have this patient come back with a stroke. So it is prudent for every internist and cardiologist to listen to the neck, and if there is evidence of a critical bruit, we should perform carotid duplex scan at least to measure the velocities, and if the velocities are critical, then it is appropriate to do a CT angiography or MRA of the carotids to make sure that you are not dealing with a critical carotid artery stenosis. Chest. Does this patient have valves, which may suggest a number of things, including congestive heart failure? And does this patient have wheezing? Because wheezing can increase the cardiac work. Heart. Of course, we are giving preoperative cardiac clearance. We have to examine the heart. Look for cardiomegaly. Does this patient have murmurs, gallops? If the patient has murmur, what kind of murmur? Is the murmur grade 3 or 4? If so, then we need to know what kind of valvular problem does this patient have. Abdomen. Of course, you look for hepatomegaly if this patient has a history of congestive heart failure, especially if it is decompensated. Extremities. We look for edema and check for peripheral pulses. Diminished peripheral pulses may suggest peripheral arterial disease, all of which add to the increased risk of cardiovascular complications in the perioperative phase. Let's talk about the lab tests that will help us to evaluate the patient's overall condition and particularly the patient's clinical risk evaluation. CBC is important. What is the hemoglobin? Does this patient have a hemoglobin of 8 or 6 or 7? If the patient is bleeding, they may have hemoglobin of 5, 6 or 7 because that becomes an added risk for cardiovascular patients with compromised coronary circulation. CMP and lipid profile can tell us about their kidney function, liver function, and electrolytes, more importantly, because cardiac patients are on diuretics along with ACE inhibitors. So they can either have low potassium or high potassium or low magnesium. All of them can precipitate cardiac arrhythmias in the perioperative phase. Electrocardiogram can tell a lot of information, but at the same time, it may be of no use in patients who are going for very low risk procedures such as outpatient endoscopy or a biopsy. Echocardiogram is primarily indicated to evaluate the left ventricular function in patients with history of known heart failure or in patients who are having unexplained shortness of breath or orthopnea. Stress testing is primarily indicated for patients with a history of ischemic heart disease or patients who have multiple risk factors for heart disease and to assess the degree of reversible myocardial ischemia. Cardiac catheterization is indicated if the stress testing or myocardial perfusion imaging shows any evidence of reversible myocardial ischemia. Pacemaker evaluation. If the patient has a pacemaker, the pacemaker needs to be evaluated by the pacemaker representative so that we can assess the pacemaker function, we can assess their battery lifespan, we can assess how much the patient is dependent on the pacemaker, and also maybe reprogram the pacemaker in order to avoid any complications in the intraoperative phase when electric cautery is used very close to the pacemaker, which can set off certain signals. Let's talk about a 12-lead electrocardiogram and look at some of the recommendations by the American College of Cardiology and the American Heart Association 2014 recommendations. It is reasonable to do electrocardiogram in patients with coronary artery disease or patients who have significant arrhythmias, patients who have peripheral arterial disease, cerebrovascular diseases, or structural heart disease. That's a no-brainer. They say routine electrocardiogram is not recommended in asymptomatic patients going for low-risk surgical procedures, such as going for endoscopy or going for a biopsy as an outpatient. Left ventricular function assessment is usually done using echocardiography or nuclear stress testing, and it is reasonable to perform an echocardiogram in a patient with unexplained shortness of breath as a preoperative left ventricular evaluation. If we are dealing with a patient with heart failure and if there is worsening of symptoms, or if the patient had heart failure who has not been evaluated in the last 12 to 18 months, it is reasonable to perform an echocardiogram to assess their left ventricular size and function prior to a non-cardiac surgery. However, routine preoperative evaluation of left ventricular function using echocardiography or nuclear stress testing is not recommended. Stress testing and myocardial perfusion imaging looking for reversible myocardial ischemia. If the patients are very active and they can exercise to a tune of greater than 10 METs, then the American Heart Association and the American College of Cardiology say it is reasonable to forego further exercise testing or cardiac imaging prior to surgery. Again, this depends on are we dealing with low or intermediate risk or high risk surgery. In patients with elevated risk or unknown functional capacity, it is reasonable to perform exercise testing to evaluate their functional capacity and also look for any evidence of myocardial ischemia, which will help us to manage these patients preoperatively so that we don't have to deal with cardiovascular events in the perioperative phase. But if you have a patient who has an exercise capacity between 4 and 10 METs, if the patient has an exercise capacity between 4 to 10 METs, it may be reasonable to forego further exercise testing with cardiac imaging and proceed with surgery. This is the recommendation by the American College of Cardiology. Coronary revascularization prior to non-cardiac surgery. Well, here's what happens. A patient comes for cardiovascular evaluation. The patient has multiple risk factors for cardiac disease or coronary artery disease, and maybe has some vague symptoms of some heaviness in the chest, some dyspnea and exertion. So we perform a perfusion imaging study. the perfusion imaging study comes back as abnormal. So to further evaluate, we send these patients for cardiac catheterization. And when we do the cardiac catheterization, if we find critical lesions and if we would have performed any intervention on these patients, whether they were going for surgery or not, then it is appropriate to go ahead and do the coronary intervention, be it putting a stent or recommending a bypass surgery. However, coronary intervention is not recommended for reducing perioperative cardiac events, cardiovascular implantable electrical devices. Quite often we have patients who have history of heart failure, who have history of arrhythmias or bradyarrhythmias, who have a pacemaker. Routinely, we are called in to evaluate and clear these patients for surgery. It is important for an internist or a cardiologist to know what type of surgery is being performed. If the pacemaker is in the left shoulder, if the orthopedic surgeon is going to work on the left shoulder joint, then it is important to communicate with the orthopedic surgeon and see how best we can optimize the condition for the intended surgical procedure. Because they use cautery, the cautery can send signals to the pacemaker, and the pacemaker may trigger certain type of activities. If it is necessary, the pacemaker can be reprogrammed as a fixed pacemaker, so it would not respond to the signals coming from the electric cautery. And by the same token, we would recommend the surgeons to use the cautery as minimal as possible and give time between the episodes so that there is minimal disturbance to the cardiac rhythm during the surgery. Now let's talk about patients who have had coronary interventions who need non-cardiac surgery. Let's say we have a patient who had a balloon angioplasty or a stent, and now 3 months or 2 months or 6 months or 8 months down the line needs an abdominal surgery for colectomy or needs a gallbladder surgery. But these patients are on dual antiplatelet agents such as aspirin and Plavix and aspirin and Eliquis or any other medications. So how do we deal with these patients? This is an exceedingly important point to focus our attention. If the patient had simple balloon angioplasty, we have to keep these patients on antiplatelet agents for 14 days, that is 2 weeks, before these patients can undergo non-cardiac surgery. If the patient had a bare metal stent, they have to be on antiplatelet agents for minimum of 30 days before they can go for a non-cardiac surgery. But it usually happens the other way around. We evaluate a patient for cardiac clearance for a surgical procedure, and we find out they have reversible ischemia, and in the cath lab we find out they have a critical stenosis. The real question comes up as, should we put a bare metal stent or a drug-eluting stent? That depends on the type of surgery this patient is going to go through. If it's a surgery that can wait for 1 year, then it is reasonable to put a drug-eluting stent. If this is a surgery that cannot wait for a year and needs to be done in the immediate period, then the cardiologist would elect to put a bare metal stent and maintain these patients on antiplatelet agents, usually dual antiplatelet agents such as aspirin and Plavix or aspirin and Eliquis for minimum of 30 days and then discontinue them for a short duration in the perioperative phase and resume the medications after the surgical procedure is done. On the other hand, if the patient has a drug-eluting stent, then it is most appropriate to wait for at least 1 year before they are cleared for an elective surgery. However, if the patient has to have the surgery, it may be reasonable after 6 months to hold the antiplatelet agents for short duration just before the surgery and resume the medications as soon as it is feasible, with the understanding that there is a risk of thrombosis leading to myocardial infarction, which has to be judged against the risk of not doing the surgery in a reasonable period. Arrhythmias. The most common arrhythmia we deal in the perioperative period is atrial fibrillation. Either the atrial fibrillation is present before the procedure, in which case we need to make sure we control the rate as best as possible, not only in the pre-operative phase, but in the intraoperative and post-operative period. And also we need to address the question of anticoagulation. Since majority of the patients with atrial fibrillation are on warfarin or other medications such as Xarelto or Pradaxa, we have to make sure that we stop these medications appropriately anywhere from 4 to 5 days before the elective procedure and resume these medications as soon as it is cleared by the surgical team. If the patient is having ventricular arrhythmias and if that person is on antiarrhythmic drugs, it is reasonable to continue the antiarrhythmic drugs until before the surgery and resume them immediately after the surgery. And I talked about the pacemaker and the importance of communicating with the surgeon and making adjustments to the pacemaker so there is no interference with the surgery as far as the surgeon is concerned, and there is continued maintenance of cardiac rhythm during the entire perioperative period. A couple of words about critical aortic stenosis and mitral stenosis. Here's the recommendation by the American College of Cardiology in year 2014. This is the recommendation from the American College of Cardiology. Elevated risk elective non-cardiac surgery with appropriate intraoperative and postoperative hemodynamic monitoring is reasonable to perform in patients with asymptomatic severe aortic stenosis or severe mitral stenosis. While this may be beyond the expertise of an internist and even everyday cardiologist, I think we have to assess the overall risk before we can clear these patients for elective non-cardiac surgery. Now let's talk about some of the cardiovascular drugs and what do we do with them. Beta blockers. Majority of the patients in the cardiology practice are on beta blockers. They are on beta blockers either for control of hypertension, they are on beta blockers for control of rate in patients with atrial fibrillation, or they are on beta blockers for congestive heart failure. It's very important, if these patients have been on beta blockers before the procedure, continue the medications until the time of surgery and resume these medications immediately in the postoperative phase as soon as these patients are able to take these medications. In intermediate or high risk patients who are going for non-cardiac surgery, it is reasonable to start these patients on beta blockers in the perioperative phase. Also, patients who have multiple risk factors such as diabetes, hypertension, vascular disease, renal insufficiency, in these patients it is reasonable to start them on beta blockers before the surgery. Let's talk about statins. Statins have gained a lot of attention in the management of cardiovascular patients. If the patients have been on statins, we need to continue these statins until the time of surgery and resume them after surgery. There is no reason to stop them for any length of time. Also, statins can be started in patients who are going for vascular surgery. Statins can also be started in patients who are going for high-risk procedures who also have moderate cardiovascular risk factors. Now let's talk about ACE inhibitors and angiotensin receptor blockers. If these patients have been on ACE inhibitors or ARBs for either hypertension or congestive heart failure, we need to make sure that we continue these medications up until the time of surgery and resume them in the post-operative phase. If we were to stop the ACE inhibitors before surgery, they need to be started immediately after the surgery as soon as the patient is able to take these medications. Antiplatelet agents. We talked about the 2 weeks for balloon angioplasty, 4 weeks for bare metal stent, and 1 year for drug-eluting stents. The antiplatelet agents should be continued. If the patient is going for elective surgery beyond these dates, beyond these time intervals, then it is reasonable to hold the antiplatelet agents for 4 to 5 days before surgery and resume these medications as soon as it is reasonable to start after the surgery. If we have a patient who is going for surgery where discontinuation of antiplatelet agents such as Plavix, then it is reasonable to continue the aspirin in the perioperative period. That brings us to the topic of aspirin. If the patients have been on aspirin, we can continue the aspirin during the perioperative phase, because if the patient has been on aspirin, aspirin has a permanent antiplatelet effect on the platelets. That means neutralizes the platelets in terms of its stickiness, so that it doesn't make sense to stop aspirin for 1 or 2 days. If we stop aspirin, we have to stop it for at least a week before a whole new batch of platelets are produced by the bone marrow. However, initiation of aspirin is not beneficial in patients undergoing elective non-cardiac carotid artery surgery who have not had previous coronary stenting. Intraoperative monitoring techniques. Transesophagealechocardiography is nowadays routinely used in patients going for cardiovascular surgery. It may also be useful in patients who are undergoing major thoracic surgery, which will help us to determine the cause of hemodynamic instability and help us to direct our management in optimizing the hemodynamics during a major thoracic or abdominal surgery. Pulmonary artery catheter or Swan-Ganz catheter, as it is called. It depends on the institution where you are trained. Some places religiously believe in Swan-Ganz catheter, in getting the pulmonary wedge pressure, in getting the pulmonary artery pressure, and determining the volume status. And there are institutions which depend on simple heart rate, oxygen saturation, urine output, and blood pressure to make their decisions about volume status or vasopressors. However, if the patient is undergoing major thoracic surgery or an abdominal surgery such as a vascular procedure, it may help us to monitor their hemodynamics. It will help us to monitor their fluid balance, and it would help us to determine what is needed to maintain the blood pressure in a patient and optimize urine output. How do we put all this information together and determine what is the risk of a patient who is going for an intermediate or high risk procedure such as colectomy, pneumonectomy, or a major gastric resection for cancer? In order to answer that question, the American College looked at more than 200,000 patients from 250 institutions, and they came up with a formula to determine the perioperative risk in patients going for non-cardiac surgery based on their medical history, physical examination, and lab evaluations. So let us visit this website, test it out ourselves, and see how this will help us to determine the perioperative risk of a patient with a cardiovascular problem going for non-cardiac surgery. Okay, let's go to the website here, and this is the website, which is www.riskcalculator.org. When you come here, you come to this main page, or you can just Google ACS risk calculator, and that will list this particular site. Then you come here and you accept their disclaimer and press continue. That brings us to this place where we input the type of surgery and the patient's findings. So let's say we want to check for colectomy for a possible colon cancer. Colectomy. So let's select this CPT code, ICD code I should say, 441.41, which is colectomy partial with skin level colostomy. Okay, that sounds like a surgery this patient is going to go through, and let's say we don't have anything else. Now here are the parameters. I'll just read it out: age, sex, functional status, emergency, ASA classification, and diabetes, hypertension, heart failure, dyspnea, COPD, kidney problem. Okay, let's fill out some of this. So we got a patient who is between 65 to 74. So this is a male patient. He's functional, he's independent, he's walking around, so no problem. This is an elective surgery, so it's not emergency. Anesthesia, he's reasonably healthy. I mean, he's got mild systemic diseases, let's put it that way. The patient is not on steroids, no ascites, no sepsis, he's not on ventilator, and this patient does have diabetes. He's taking oral hypoglycemic drugs. Of course, 66 years old, he's got hypertension. Well, maybe he's got some congestive heart failure, but it's controlled. He doesn't have dyspnea. Let's say the heart failure is controlled. Current smoker within a year, say yes, why not? Let's say yes. History of COPD, let's say he doesn't have a lung problem, at least to start with. The patient is no kidney problem, he's not on dialysis, no history of acute failure, and he is like 70 inches. And let's give him some mild obesity, 264 pounds. Golly, he's 120 kg, so he is moderately obese. So let's see what his is perioperative risk. Here we go, ladies and gentlemen. The average risk of a patient of this nature is 27% of serious complications in the perioperative period. Any complication is in the range of 33. That is, we are talking about 1 out of every 3 person going for a colectomy with a history of diabetes, hypertension, heart failure, smoking, and obesity, who is 65 to 74 years old, has a 33% chance of having any type of complications after the surgery. And the mortality, even though it is only 0.9%, but the morbidity is what is quite impressive in this situation. Let's go back and let's look at a low-risk surgical patient, all right? Let us say we are dealing with a gallbladder surgery. Cholecystectomy, laparoscopic cholecystectomy, that's better. All right, so let's say this is a young person who is 65 to 75, is fine, and it's a female, is independent, all these things, and has no history of diabetes, no hypertension. This is a 40-year-old person. You don't expect him to have all these things. No dyspnea, not a smoker, and no COPD, no kidney problem. And let's see what the risk is. There you go. So this is pretty good in assessing the risk of a patient who is going for low-risk surgery versus intermediate or high-risk surgery. So by using this, you can calculate, is the patient at low risk of having perioperative complications or mortality, or at high risk. As you can see, a patient going for a simple laparoscopic cholecystectomy, the mortality is 1 in 1,000 patients, and perioperative complications are like 2 to 3%, as compared to a patient who is 65 or older, who has hypertension, diabetes, congestive heart failure, who is going for colectomy, who has a 33% chance of having perioperative complications. So, ladies and gentlemen, this is in a nutshell preoperative cardiac evaluation and cardiac clearance. I am Dr. NIK NIKAM. I hope this has been useful to you. Thank you so much for watching, and please do subscribe to our YouTube channel, and we will see you next time. Thank you for your attention.